Welcome back to the deep dive. This is the place where we take the densest source material, analyze it, and distill it into high-yield, actionable knowledge.
And today we are really getting into a foundational surgical specialty.
We're talking pediatric orthopedics. And it's this fascinating field where a patient's own growth is, well, it's both the biggest challenge and the most powerful tool you have.
That is the perfect summary. I mean, the potential for an immature skeleton to heal and remodel is just incredible.
But there's a flip side.
A huge flip side. If injury or, a disease gets in the way of that growth, the result can be a progressive, almost catastrophic deformity.
So for those of you who are deep in revision or maybe just looking for a structured refresher, we want to be very clear.
We are interpreting Chapter 44 from the 28th edition of Baily and Love's Short Practice of Surgery.
Right. This deep dive is designed to be your ready reckoner. It's a conversation built on, hopefully, some useful logical anchors and clinical rationale.
But, and this is the important part, it is absolutely not a replacement for reading the primary source material itself.
Our mission is really just to unpack the key concepts. We'll go from the molecular principles of bone formation all the way to the complexity of, say, stabilizing a child's hip.
And hopefully we can do it in a way that ensures those critical details actually stick when you need them most.
It all comes down to that paradox you mentioned.
It does. The pediatric skeleton is high risk, high reward. If you get the management right, nature really does take over and can correct a surprising amount of residual deformity.
But if you get it wrong?
If you get it wrong, you find yourself fighting against years and years of worsening alignment.
Okay, so let's start with the absolute bedrock of this specialty. Before we even touch on specific conditions, we need to understand the physics of it.
Right.
What are the two essential, let's call them operating instructions, for pediatric bone that really dictate every treatment decision?
The first one is the growth regulator. It helps us understand how mechanical load dictates both the length and the shape of a bone.
And that is the Hutter-Volkmann principle.
The Hutter-Volkmann principle, yes.
Okay, so let's unpack that. I mean, the principle itself sounds deceptively simple, right?
No.
Pressure inhibits growth and tension stimulates it.
It does, but its implications are huge.
So what does that really mean in the context of the physis of the growth plate itself?
The best way to frame it is as the bone's push-pull dynamics.
Okay.
Think of the growth plate as a little factory. It's laying down cartilage, which then gets turned into bone.
Right, the process of enchondral ossification.
Exactly. Now, if you introduce sustained excessive compressive forces, so too much push, you effectively slow down that factory's output.
Which leads to inhibited growth, but only on that side of the bone.
Precisely. And conversely, if you introduce tensile forces, a constant pull, you actually stimulate the physis. You can potentially accelerate growth.
So we're talking about asymmetrical forces causing asymmetrical growth. I can immediately see how this translates clinically. Say, with a child who develops scoliosis. The continuous compressive load on the concave side of that curve in the spine
is going to inhibit the vertebral growth on that side.
While the tensile forces on the convex, the outer side, they encourage overgrowth.
And that accelerates the curve. It becomes a vicious cycle.
Right. And what about in the hip? That's a classic example.
Developmental dysplasia of the hip, DDH, is a perfect illustration. If the femoral head is poorly seated in the socket, you get this abnormal concentrated pressure on one part of the acetabulum.
And that pressure inhibits the growth of the socket.
It keeps it shallow. I mean, that is the very definition of dysplasia.
But, and this is the hopeful part, if we can improve that biomechanical environment, say by reducing the hip and holding it securely in place,
you relieve that abnormal compression, and then the Hutter-Volkmann principle kicks in, and it allows the acetabulum to remodel and develop normally.
So it shows us that growth isn't just a passive timeline, it's an active response to its environment.
Absolutely. Which leads us directly into our second foundational rule. This one described how the bone's internal structure adapts, not just its length.
And that's Wolff's Law.
Wolff's Law. I like to call this one the body's construction foreman.
Okay, I like that metaphor.
It basically dictates that the bone architecture, we're talking about its internal structure, its density, its thickness, will adapt precisely to the stresses and strains that are applied to it.
So bone deposition and resorption are constantly adjusting to meet functional demands.
Constantly.
This is the principle we rely on for every single fracture we treat. We do the initial engineering, we align the bone.
And then we trust the body, as long as the mechanics are right, to handle the rest.
That disorganized fracture callus you see at first.
Yeah.
It eventually remodels along the lines of maximum stress.
It becomes stronger and denser exactly where the load demands it to be.
The implication for pediatric orthopedics, then, is that alignment is often more important than getting immediate, perfect anatomical reduction.
Provided, of course, the child is young enough and has significant growth potential remaining.
Right. So we can sometimes accept a certain degree of angulation in a fracture because we know that subsequent growth and remodeling driven by Wolff's law and gravity will correct it over time.
Yes, but there's a huge caveat here.
The laws only work if the factory is functional.
Exactly. What happens when the underlying growth mechanism, the physis itself, is defective?
That's the critical contrast you have to make.
It is. In a condition like Blount's disease, the problem originates from a dysfunctional growth plate in the tibia.
So the asymmetrical growth, the severe bowing.
It just proceeds regardless of normal mechanical forces. The factory itself is broken.
So just improving the environment isn't enough.
No. You need external correction like guided growth or an osteotomy to impose a different trajectory. You're fighting an inherent defect, not just a positional error.
Okay, so understanding how growth is regulated naturally leads us back to the very, very beginning. How is the limb designed in the first place?
The blueprint phase. Musculoskeletal embryology.
And this is where most congenital limb anomalies are actually established.
It's a spectacular feat of, rapid biological engineering. Limb development is concentrated into this remarkably short and incredibly crucial window.
We're talking between 4 and 8 weeks after fertilization.
Just 4 weeks. And that brevity explains why teratogenic exposures during this specific time can have such profound, devastating effects.
And this rapid, complex development isn't random. It's coordinated by these specific, localized signaling centers.
The limb's development GPS.
I like that. Let's detail these 3 anchors, starting with the one that controls length.
That would be the apical ectodermal ridge, or the AER.
Okay, AER.
The AER sits right at the tip of the developing limb bud, and it guides differentiation in the proximal to distal direction.
So from the shoulder down to the fingertips.
Exactly. Think of it as controlling the length of the limb segments, and it does this primarily through fibroblast growth factors, or FGFs.
And the experimental data from this is really illuminating.
It's incredible. If researchers excise the AER from a developing limb bud,
The limb development just stops right there, distal to where it was removed.
correct. Removing it results in a truncated limb, which perfectly mimics the presentation of many congenital amputations or deficiencies.
But it has a second function too, doesn't it?
A crucial one. It also prevents the programmed cell death, the apoptosis that's required to separate the digits.
So if the AER hangs around for too long,
You get syndactyly fused digits
Oh,
because the webbing between them isn't reabsorbed.
okay, so that's length. Our second center controls the front to back axis,
That is the zone of polarizing activity, or ZPA.
the ZPA.
This center dictates the posterior to anterior axis, so, the antero-posterior axis.
And it functions through one of the most famous signaling molecules in all of embryology.
The sonic hedgehog protein. Shh.
So the ZPA is what determines whether we have a thumb on the anterior side and a little finger on the posterior side, all in the correct sequence.
It is, and the experimental evidence for this is almost surreal.
This is the one where they graft it onto the other side.
That's the one. If you take ZPA tissue and graft it onto the anterior margin of a normal limb bud,
You get a complete mirror duplication of the distal limb.
a hand with 5 mirrored fingers. Polydactyly. It's the most direct illustration you could imagine of the ZPA's role as the anteroposterior organizer.
Okay, and finally the third center, which governs orientation.
That is the wingless type Wundt center. This is an ectodermally driven signaling cascade.
And it influences the dorsal to ventral axis.
The top to bottom axis, yes. It's crucial for the overall limb alignment and establishing the different skin surfaces. All 3 of these centers have to communicate seamlessly for a structurally sound limb.
Let's pause here for a quick conceptual check. We've talked about that incredibly tight timeline, 4 to 8 weeks.
Mm-hmm.
So the question for you to think about is, why is this window not just about the limbs, but a potential warning for systemic risk? If you need to, just rewind a minute and recall those three signaling centers and what they do.
It's a critical question.
So what's the answer?
The answer is that the systems for fetal limb formation are developing at the exact same time as many other vital organs.
We're talking cardiac, renal, gastrointestinal systems.
All of them. So any factor, whether it's genetic or environmental, that disrupts those complex processes between 4 and 8 weeks is very rarely going to be localized to just the limb.
So the key takeaway for a clinician is what?
That a severe fetal limb anomaly must trigger an immediate search for potentially life-threatening systemic disorders that were forming at the same time.
The limb is often just the visible manifestation of a much deeper, wider issue.
Exactly. That structural insight is vital. Once we understand the blueprint, we can start to analyze the ways development can go, well, slightly off course or completely derail.
Right. And this is where a lot of parents first interact with a specialty. They bring their children to the clinic worried about how they walk.
And the good news, according to our source material, is that if the alignment issues, we're talking bow legs, knock knees, in-toeing, are symmetrical
Symptom-free?
and follow a predictable pattern.
They're usually just variations of normal development.
And they require education and reassurance, not intervention.
So we have to teach practitioners and parents about what's called the physiologic curve.
Or the predictable S-curve of growth, yes. This curve starts in infancy with a very specific alignment.
All children begin with physiological bow legs, varus.
Correct. Often accompanied by some degree of internal tibial torsion as well.
This varus stage is really just the fetus unfolding from the womb, where that adducted position is natural.
That's right. But this starts to reverse around 18 months of age. And by age 2 to 3 years, the alignment progresses dramatically to the complete opposite.
Physiological knock knees, valgus.
And this peak valgus can be really concerning to parents. I mean, sometimes it measures 12 to 15 degrees.
But then it slowly regresses.
It does. It moves back toward the normal adult position, which is a tibiofemoral angle of about 7 degrees of valgus, usually by age 7 or 8.
Okay, so if a parent brings in a 5-year-old with knock knees and they are symmetrical and pain-free, the primary management is just reassurance and observation.
And noting that they are progressing back toward normal.
So what breaks that rule?
Yeah.
When do we have to investigate?
We stop observing and we start investigating immediately if the deformity is severe, so way outside the expected range for that age.
Or if it's distinctly asymmetrical?
Or if the child is symptomatic. And by that I mean they have pain, difficulty running, or they're tripping excessively.
Those are the red flags.
They are. And they demand radiographs to exclude specific pathology. Most commonly, you're looking for a previous physical trauma, active rickets, or an underlying skeletal dysplasia like achondroplasia. #B. In-toeing gait, the negative progression angle.
In-toeing, which is defined as a negative foot progression angle, is another huge reason for referral.
It is, and we need to systematically check the source of the torsion. Is it the hip, the tibia, or the foot?
So let's start proximally at the hip.
Yeah.
Persistent femoral neck anteversion.
Right. Anteversion is basically a twist in the femur that allows the head to face forward into the socket.
And all infants are born with a high degree of this, which then spontaneously corrects by rotation as the child grows.
It does, but sometimes it persists.
So what's the clinical presentation of persistent anteversion?
When the child is lying prone on the exam table, they will demonstrate an excessive amount of internal rotation of the hip.
Sometimes up to 90 degrees.
Yes, but they'll have a severely limited ability to externally rotate that same extended hip.
And so the child compensates by walking with their knees and feet pointing inward.
And they often sit in that characteristic W position because it's their most comfortable posture.
Since spontaneous correction is the norm, what's the hard line for intervention? When do you step in?
Generally, we wait until the child is well past 10 or even 12 years of age.
You wait that long.
We do. If the anteversion is still severe, say greater than 50 degrees, and it's demonstrably causing functional difficulties.
Like significant gait disturbance, tripping, or patellofemoral instability.
Then a corrective rotational osteotomy of the femur may be justified. But we wait that long, precisely because of Hutter-Volkmann and Wolff's laws. We're hoping the forces of gravity and development will correct it naturally.
Okay, moving down to the shin bone. Internal tibial torsion.
This is a twist in the tibia itself. It's often associated with those physiological bow legs in the infant stage.
And we assess this clinically with the 5-foot angle.
The angle between the axis of the thigh and the axis of the foot, yes. And just like femoral anteversion, it typically corrects spontaneously, usually by age 4.
And if it persists?
It's less common to intervene surgically for this than for femoral anteversion, but the principles of an osteotomy would apply if function is severely impaired.
And the most distal cause, the foot itself, metatarsus adductus.
This is an isolated forefoot adduction. It makes the foot look bean-shaped.
Right.
If the foot is flexible, and by that I mean we can passively correct the forefoot to a neutral position, it is almost always physiological and corrects spontaneously by age 2 to 4.
And for rigid cases?
For rigid cases, you can try conservative measures like serial stretching or casting, but the vast majority of in-towing resolves without any surgical intervention whatsoever.
Okay, now let's synthesize those concepts into one functional unit.
Yeah.
Miserable malalignment syndrome. The name itself suggests a confusing compensation pattern.
It does. And this syndrome really highlights the necessity of assessing the entire kinetic chain.
What's happening here?
You have persistent femoral anteversion, so the hip is internally rotating.
Being compensated for by external tibial torsion, the tibia twists outward.
Exactly. And the net result. The foot progression angle looks perfectly normal. The feet point straight ahead.
But the child is symptomatic. Why?
Because the knee joint, which is caught in the middle of this twisting force, is constantly experiencing abnormal rotational stress.
So the child presents with, what, vague knee pain?
Vague, exercise-related knee pain, patellar instability, or chronic tripping, despite the straight appearance of their gait.
So the treatment has to address both components of the torsion to derotate the entire limb.
It does. It's a classic example of how a normal-looking outcome, straight feet, can mask significant underlying pathology. #C. The flat foot spectrum.
Okay, the flat foot. This is arguably the most common musculoskeletal concern brought to the pediatrician.
Without a doubt.
And it's important to emphasize again that flat feet are the physiological norm for children under 3 years old.
Because of that fatty pad that's padding the arch, yes.
We also have to manage expectations here.
We do. About 15% of adults maintain a flat foot, often due to familial ligamentous laxity, and they are entirely asymptomatic.
So the real work for the clinician is to distinguish the benign, flexible flat foot from the rare, rigid, pathological flat foot.
That distinction dictates everything.
So let's anchor the diagnostic move, the tiptoe test. What does Table 44.3 in the source material tell us about the flexible, painless flat foot?
Okay, so when the child stands on tiptoe, the foot mechanically inverts and the arch, it magically reappears.
And the heel corrects from valgus, that outward tilt into varus, an inward tilt.
Crucially, the subtalar joint demonstrates full, pain-free movement, and the patient is usually asymptomatic.
So what's the most important clinical instruction?
No treatment is required. Orthos is, arch supports. They only treat symptoms if they exist. They do not change the ultimate anatomical outcome.
So if the arch reappears, it's essentially a foot that has the potential for an arch, but it's just temporarily flattened by load and ligament laxity.
That's a perfect way to put it.
Now contrast that with the concerning type.
The rigid, symptomatic flat foot. This is the pathology. When this child stands on tiptoe, the arch fails to return.
And the heel remains fixed in valgus.
And the key sign is restricted and often painful subtalar movement. This rigidity signifies a structural block or an inflammatory process.
So what are we most often looking for when we see that kind of rigidity?
The most common structural cause is something called tarsal coalition.
Tarsal coalition.
This is a failure of segmentation of 2 or more of the tarsal bones in the midfoot or hindfoot.
Creating a rigid bony bridge.
A bony bridge, yes. Like a calcaneonavicular bar or a talocalcaneal coalition. And this bridge limits movement, causes peroneal spasm, and leads to the pain and the fixed valgus posture.
And this requires investigation.
Oh, yes. This condition requires imaging, usually a CT scan and often surgical management, to either excise the bar or fuse the painful joint.
So the stiffness, the lack of correction on active tiptoe standing,
Yeah.
that is the ultimate diagnostic anchor for serious pathology in a flat foot.
It is. It moves the diagnosis from a variant to a disease process. The clinical sign is the rigidity. The underlying pathology is often the coalition.
All right, now we move into conditions where the internal structure or the quality of the bone itself is fundamentally flawed.
Right.
And we need to be alert to these clinical clues, these red flags that suggest systemic issues that go beyond the obvious deformity.
Those red flags are crucial. You have to look for the non-musculoskeletal signs.
Like what?
A dermal skin dimple or maybe a tuft of hair over the spine suggests spinal dysraphism. A vascular malformation or those characteristic severe featureless limbs, as you see in arthrogryposis multiplex congenita or AMC.
Where you have stiff joints and very little subcutaneous tissue.
All of these things demand an immediate investigation for a wider skeletal dysplasia. Hashtag A, congenital abnormalities and skeletal dysplasias.
Let's start with achondroplasia. This is the most common cause of disproportionate short stature. What's the molecular anchor here?
It's a classic example of a gain-in-function mutation in the FGFR3 gene on chromosome 4.
Okay, so gain of function.
Right. FGFR3 normally acts as a negative regulator of growth, like a brake.
And the mutation makes it hyperactive.
It makes the brake get stuck on, strongly inhibiting the proliferation of chondrocytes in the growth plate.
And since this primarily affects enchondral bone formation bone replacing cartilage, the long bones are the most severely affected.
Correct, which is why the presentation is so immediately recognizable.
You get disproportionate short stature, short limbs, but a normal-sized trunk, characteristic facies, a waddling gait.
Due to hip flexion contractures, yes. And radiographically, we see short, thick bones, widened metaphyses, and those distinctive squared-off pelvic wings.
What's the most serious clinical implication we need to be aware of?
The neurological risk. The base of the skull, which also develops via enchondral ossification, is underdeveloped.
Leading to a small foramen magnum.
Exactly, and this increases the risk of craniocervical junction compression and hydrocephalus, which can absolutely be life-threatening.
Okay. Next, we have an overgrowth disorder, hereditary egretary, multiple exostasis, or HME.
HME is caused by a loss-of-function mutation in the EXT1 or EXT2 genes.
So the opposite problem.
The opposite problem. These genes are necessary for heparin sulfate synthesis, which regulates local growth factors near the physis.
And the result is the uncontrolled formation of these exostasis.
Benign osteochondromas. They have a cartilaginous cap sitting on a bony stalk, and they characteristically grow away from the joint.
And these lumps grow with the child and can cause mechanical symptoms, like impingement or pressure on nerves and vessels.
They can.
What's the long-term risk we have to monitor for?
The really serious risk is if one of the exostases continues to grow after the patient has reached skeletal maturity.
And that suggests?
It's rare, but it suggests malignant transformation into a secondary peripheral chondrosarcoma.
And what's the other major complication?
The progressive limb deformity. The differential growth between the paired forearm bones, the radius and ulna, often causes radial head dislocation and progressive angulation.
Okay, finally in this structural category, let's talk about fibrous dysplasia.
This is a localized defect where there's a failure of normal osteoblastic differentiation.
So normal bone is replaced by what?
By immature fibrous stroma. It's often monostotic, affecting just one bone and benign, sometimes only discovered incidentally after a fracture.
But the polyostotic form is a different story.
It is. It causes significant pain, limb deformity, and pathological fractures because of that inherently weak fibrous tissue.
And what's the rare systemic combination we need to anchor?
That would be the McCune-Albright syndrome.
The triad.
You need to anchor this triad. Polyostotic fibrous dysplasia, combined with endocrine features like precocious puberty.
And the large, irregular, non-hairy skin pigmentations.
The coast of Maine cafe au lait spots, the presence of all three is extremely rare, but it's highly diagnostic. Hashtag B metabolic disorders.
Shifting gears now to metabolic disorders. Here, the issue isn't the initial blueprint, but the quality of the materials being used.
And that's a great way to put it. Let's look at rickets.
So what's the core pathology?
It's defined by inadequate mineralization of growing bone. The bone matrix, the osteoid, is laid down perfectly fine, but it fails to mineralize correctly.
Which leads to soft bones that bow under weight-bearing stress.
Right. And the causes are vast. Nutritional vitamin D or calcium deficiency is the most common.
But you can also have genetic causes, like X-linked hypophosphatemia, or underlying issues in the gut or kidney.
Yeah.
So how does this appear on an X-ray? We need a clear radiographic anchor.
The radiographic anchor is classic, regardless of the cause of active rickets. You see widened fezzes. The growth plate looks like a wide, radiolucent band with characteristic cupped, flared metaphyses.
And that flaring represents the unmineralized osteoid tissue that's bulging under the load.
It's exactly.
The management approach here is layered, isn't it? You can't just correct the deformity.
You absolutely cannot. You have to fix the underlying metabolic problem first.
So medical stabilization comes first.
Always. Adequate vitamin D and mineral supplementation or specific drug therapies for the genetic forms of rickets.
And only once the mineralization is stabilized and the growth plates are starting to harden can you address the residual deformity?
Correct. For active progressive deformity, we rely heavily on guided growth techniques.
So you use temporary epiphysiodesis, a plate, and screw on the faster-growing side of the bone.
To allow the slower side to catch up, you're basically using that Hutter-Volkmann principle to steer the bone straight.
Okay, our final metabolic anchor is osteogenesis imperfecta, OI, or brittle bone disease.
OII. This affects the fundamental structural protein of the entire skeleton.
It's defined by a qualitative and/or quantitative abnormality of type I collagen production.
Right. And since type I collagen is the primary protein in skin, tendons, teeth, and bone, the disease is systemic.
Which explains the classic clinical triad you see in many types.
Frequent recurrent fractures.
Ligamentous laxity.
And the distinctive blue sclerae. The white of the eye appears bluer because the thin sclera allows the underlying choroidal layer to show through.
The treatment here is twofold. You have to stabilize the bone internally and fortify it pharmacologically.
The core pharmacological strategy is the cyclical administration of bisphosphonates like pamidronate or zoledronate.
And these are powerful inhibitors of osteoclast activity.
They inhibit bone resorption, which decreases bone turnover, reduces pain, and significantly lowers the fracture rate.
That's surgically.
Surgically, due to the high likelihood of refracture, intramedullary fixation techniques are preferred over plate fixation.
Things like telescoping rods that can accommodate growth.
Exactly, followed by rapid, aggressive rehabilitation to maintain muscle strength and mobility.
So the key takeaway for this whole section is to always analyze the problem's location.
Right. Is it a defect in the structure, like achondroplasia affecting the growth plate factory?
Or is it a defect in the material, like rickets or OI, affecting the quality of the bone being built?
That distinction is what separates the surgical management from the medical management.
The hip. This is where pediatric orthopedics often becomes most urgent and most complex.
It is.
We have three major non-infectious pathologies that every practitioner absolutely must be able to distinguish, starting with the most critical one in the neonate: developmental dysplasia of the hip, or DDH.
DDH is a broad spectrum. It ranges from a mild acetabular dysplasia, so a socket that's just too shallow, all the way to a hip that is completely dislocated and irreducible.
And the stakes are immense. Failure to diagnose or adequately treat DDH before a child starts walking
Leads to lifelong functional impairment. It's that serious.
So let's anchor the risk factors, because this defines which infants require focused screening. We can use the 5 Fs.
Plus, breech presentation and cultural factors. The risk factors are 1, female, 4 to 5 times more common, likely linked to maternal hormones causing joint laxity.
2, firstborn.
Restricted space in the uterus. 3, family history. This is the strongest predictor.
4, fetal position. The left hip is more common due to the typical fetal lie.
And 5, associated postural feet or spinal issues like torticollis or metatarsus adductus.
And crucially, breech presentation, especially extended breech, elevates that risk dramatically.
It does. And we have to talk about environmental factors.
The cultural context of swaddling.
Yes. Swaddling practices that keep the baby's legs tightly wrapped together and adducted can significantly exacerbate instability.
Because you're forcing the hip out of its safe zone.
Exactly. Conversely, carrying a baby astride the mother's hip naturally promotes hip flexion and abduction, the stabilizing position, and is actually protective. ### TDA. Developmental dysplasia of the hip, DDH.
Diagnosis in the neonate relies on physical instability tests and imaging. So let's review the classic clunks.
The 2 instability tests are key. The Ortolani test is the test of reduction.
So the hip starts dislocated.
Yes, and the examiner abducts it while lifting the trochanter. A soft clunk means the hip has reduced into the socket. This signifies a dislocated but reducible hip.
And the Barlow test is the test of dislocatability.
Here the hip is already reduced. The flexed hip is adducted, and the examiner applies downward posterior pressure.
And a clunk here means the hip has subluxed or dislocated out of the socket.
Correct. Both are tests for instability and are most reliable in the first 6 weeks of life.
But we have to remember the more subtle signs in older infants.
Limitation of abduction, thighfold asymmetry, and shortening of the leg, which is the Galeazzi sign.
And if the dislocation is bilateral, everything can look deceptively symmetrical.
Which is why imaging is so important. Ultrasound is the diagnostic tool of choice up to about 5 months of age.
Because the femoral head and acetabulum are still mostly cartilage.
Exactly. And we typically screen between 4 and 6 weeks, not right at birth, because many of those initial instabilities correct spontaneously during that time.
But if you wait too long, say after 6 months,
The soft tissues adapt and contract, making closed reduction much, much harder.
Okay, let's use our case study prompt to really anchor the importance of this timing.
Good idea.
Check in 2. Case study. A 4-week-old baby who was born extended breech is noted to have asymmetric hip abduction, but there's no palpable clunk on either Ortolani or Barlow testing. What is the next diagnostic step, and what is the crucial consideration in management based on the age and risk factors?
Okay, so the next step is a targeted ultrasound screening. No question.
Even without a clinical clunk.
Absolutely. Given the breech risk factor, imaging is mandatory to look for subtle dysplasia or instability.
And the crucial consideration
Is that even if the hip appears stable on exam, if that ultrasound shows dysplasia, early treatment is required.
typically a Pavlik harness.
Yes. We have to seize this early window because intervention now utilizes the massive remodeling potential of the neonatal skeleton. If this fails, the management path radically changes.
Okay, so let's break down that age-dependent management. What does a clinician do when they successfully identify a dislocated or unstable hip in a neonate, someone under 4 or 6 months?
The treatment standard is the Pavlik harness. This is a dynamic splint.
It holds the hips in that safe zone of flexion and abduction, but it allows movement.
It does. The key is gentle repositioning. The harness must not force the hip into a rigid, extreme position.
And why is forcing the reduction so dangerous?
Because of the risk of 2 major complications: a vascular necrosis, AVN, of the femoral head, and femoral nerve palsy.
AVN is caused by excessive flexion and abduction, compressing the vascular supply to the epiphysis.
Right. If the hip does not successfully reduce within 3 weeks in the Pavlik harness, or if the child is over 6 months old, the harness is discontinued.
Why?
Because the soft tissues have contracted and further dynamic splinting just risks AVN without any benefit.
So once we cross that 6-month threshold, soft tissues have become a formidable obstacle.
They have. For infants between 6 and 18 months, if closed reduction is attempted under general anesthesia,
An EUA.
the surgeon almost certainly needs to perform a soft tissue release, a tenotomy of the adductor longus, or a psoas release to remove the mechanical blocks to reduction.
And if that closed reduction fails?
Then we move to open reduction.
And what are the surgical approaches to open reduction, and why are they age-dependent?
If it's performed early, say between 6 and 24 months, the medial approach is often favored.
Because it's less invasive.
It's less invasive and it addresses the main soft tissue blocks like the psoas tendon very efficiently.
But if the child is older, or you need better visualization,
Then the anterior approach is used. But regardless of the approach, the hip is stabilized and held in a spica cast for several months.
and for the older child, over 18 months, who presents late.
These children require bony procedures because the acetabulum is now so significantly shallow that it will not remodel adequately on its own.
So you have to combine the open reduction with a pelvic osteotomy.
Like a Salter innominate osteotomy to reorient the acetabulum and improve coverage of the femoral head.
And often a femoral shortening and derotation osteotomy at the same time.
Yes, to reduce the pressure and tension on the joint, which prevents AVN, before you put the leg in the spica cast.
So what's the point of no return for this kind of surgery?
The source material indicates that the potential for acetabular remodeling drops off steeply after age 3 or 4.
So surgery is generally contraindicated when?
Over the age of 6 to 8 years in bilateral cases and 8 to 10 years in unilateral cases, the risks of surgery, like AVN and stiffness, just outweigh the decreased potential for a durable functional result.
And the major long-term consequence, even with successful early treatment, is that heightened risk of early secondary osteoarthritis.
The joint is never truly normal. #B Legg-Calvé-Perthes disease, the dying and rebirthing hip.
Okay, the second hip pathology is Perthes disease.
Legg-Calvé-Perthes disease, yes. This is a vascular necrosis of the proximal femoral epiphysis. It's a very peculiar, self-limiting disease.
Predominantly affecting boys aged 4 to 7 years.
It is, and the core tragedy of it is that the damage, the deformity, occurs during the period of bone collapse.
So let's detail that natural history, the cycle of the dying and rebirthing hip.
The cycle has 4 stages. First, a vascular change. The blood supply is compromised, and the bone dies. Necrosis,
Second stage.
fragmentation and collapse. The dead bone is weak and it collapses under weight bearing. This is the critical stage where the femoral head loses its spherical shape.
Then comes revascularization and resorption.
Blood vessels return and the body begins to absorb the dead bone.
And finally, reossification and regeneration.
New bone is laid down, and the head begins to heal, hopefully regaining its sphericity. But this whole process can take 2 to 4 years.
So the entire long-term outcome is dictated by how much shape change happens during that second stage, the collapse.
Entirely.
Clinically, how does this present?
The child typically presents with a limp, often intermittent, and pain,
And critically, because of Hilton's law,
which links the nerve supply of the hip, knee, and ankle.
the pain is often referred to the knee.
Yes, a limp and knee pain in a 6-year-old boy is perthas until you can prove otherwise.
The primary management goal is containment. What does that mean in practical terms?
Containment means ensuring that the vulnerable, soft femoral head is held deep within the acetabulum.
So the socket acts as a mold to prevent it from collapsing into a non-spherical shape, like a mushroom cap.
Exactly. And management begins with non-operative measures. Maintaining a full range of movement, particularly abduction and rotation, through physiotherapy.
Now wait a second. If the child is in pain and the bone is literally collapsing, why are crutches or wheelchairs discouraged? Shouldn't we be offloading the joint?
It's a great question because it's counterintuitive. Offloading is not the goal here.
Why not?
Rest often leads to stiffness and muscle atrophy. But more importantly, crutches and non-weight bearing often promote a posture of flexion and action.
Which brings the femoral head out of the socket.
The exact opposite of containment. We want gentle, managed weight bearing within the child's pain tolerance, all while maintaining movement.
So when do you choose surgery?
Surgery is reserved for hips that are deemed at risk of severe deformity based on classification systems, like Herring's lateral pillar classification.
And early surgeries for containment.
Yes, things like a varus derotation femoral osteotomy or a pelvic osteotomy like a Salter to physically cover the head.
And late surgery.
Late surgery is purely for salvage once the deformity is already fixed. You're aiming to improve joint congruity and reduce impingement with something like a valgus osteotomy or an osteoplasty. ##C, slip of the capital, upper femoral epiphysis. SEFECV.
Okay, moving to our third major hip pathology, SCFE. This one typically strikes later during the pubertal growth spurt.
Right.
What is the mechanism of the slip?
SCFE is essentially a type I stress fracture through the physis, through the growth plate,
And during puberty, rapid growth combined with hormonal changes
which reduce physeal strength.
makes the growth plate the weakest link.
It does. And the sheer force, which is exacerbated by increased weight, obesity is a huge risk factor, causes the epiphysis to slip postero-inferiorly relative to the metaphysis.
The clinical presentation is similar to Perthes in one crucial way, the referred pain.
Absolutely. The presentation is characterized by pain in the hip, the thigh, or most often the knee.
And on examination,
You'll see a short, externally rotated limb, and when the patient tries to flex their hip, the leg automatically rotates externally.
that's the classic obligate external rotation upon flexion.
It is. This is an urgent diagnosis.
The classification system here is vital because it dictates the timing of surgery. Loader's classification focuses on stability.
Stability is the anchor. An unstable slip means the patient cannot bear any weight at all on that limb, even with crutches.
And this is a surgical emergency.
It is, because the constant micromotion and instability severely compromise the blood supply, giving it an AVN risk that's comparable to a displaced femoral neck fracture.
What is the urgent treatment for that unstable slip?
First, immediate admission and strict non-weight bearing. Then, under general anesthetic, a single, gentle maneuver is performed to move the externally rotated limb back into neutral.
And, crucially, you might need an immediate capsulotomy.
You might. This is done to relieve the hemarthrosis, the bleeding in the joint, and the intracapsular pressure, which can tamponade the blood vessels and cause AVN. Stabilization has to happen within 24 hours.
And for the much more common chronic or stable slip, where the patient can still bear weight.
The standard treatment is immediate pinning in situ with a single cannulated screw.
The screw crosses the growth plate.
It stabilizes the epiphysis and prevents any further slip. The goal is simple. Just stop it from slipping further. We accept the existing deformity.
Because attempting an aggressive, acute correction carries an unacceptably high risk of AVN.
Exactly.
So what happens when the deformity is severe, even if it's stable? When is a delayed realignment osteotomy justified?
If the deformity is severe and causes chronic impingement, femoroacetabular impingement, or FAI, or significant functional limitation after the physis closes,
then a later realignment osteotomy may be needed.
it may. But the ideal site The physis is avoided because the AVN risk is too high,
So you use an intertrochanteric osteotomy in the femur instead.
which is safer surgically, but it's technically challenging because it doesn't precisely correct the deformity at its source, which is the physis.
And finally, the critical preventative step for SCFE,
Prophylactic pinning of the contralateral hip, it's strongly indicated in several groups.
like children with hormonal deficiencies.
Hypothyroidism, panhypopituitarism, yes. Or in bilateral cases, or for those who are extremely young, so pre-adolescent, at the time of the initial slip.
The bottom line is, if one hip has slipped, the other is extremely at risk due to the same underlying biological susceptibility.
It really is.
Okay, moving down to the knee and the lower leg. Many adolescent complaints are these self-limiting traction injuries.
They are.
Let's start with the two common epiphysitis conditions.
First, Osgood-Schlatter disease. This is a traction epiphysitis, so inflammation at the institution of the patellar tendon onto the tibial tubercle.
A repetitive strain injury, typically seen in physically active, running or jumping adolescents.
That's right.
And the diagnosis is purely clinical. Localized pain, tenderness, swelling over the tubercle, made worse by jumping or kneeling. We generally skip x-rays.
We do. We only x-ray if the presentation is atypical, unilateral, or suggests something more sinister like a malignancy.
And treatment is simple.
Relative rest, modification of activity, and analgesia. The condition resolves entirely when the tibial apophysis fuses, which usually happens by age 15 to 17.
Okay, now for a far more serious condition that leads to progressive worsening deformity. Blount's disease.
This is pathology, not physiology.
And a crucial differential diagnosis for persistent bow legs.
It is. Blount's disease is caused by disordered, often premature, growth specifically in the posteromedial proximal tibial physis.
And this asymmetrical growth leads to a progressive and severe tibia vara, bow legs.
Yes, with the characteristic sharp, beak-like proximal tibial angulation that you can't correct just by positioning.
Since it's progressive, early intervention is required. What's the surgical philosophy?
If it's diagnosed in a young child, the initial intervention might be bracing, but often definitive treatment involves surgery.
A proximal tibial osteotomy to correct the acute angulation.
Yes, and this is often combined with an epiphysiodesis, a procedure to stop or slow growth on the lateral side of the physis.
To prevent recurrence and allow the medial pathological side to consolidate its healing.
Exactly. If the patient is near skeletal maturity, we might just use the osteotomy and accept the remaining growth.
That brings us back to the importance of distinguishing different types of tibial bowing. Let's anchor the three clinical types based on where the apex of the bow is.
Okay. Number 1, Blount's disease. The apex is medial and proximal, causing that progressive, sharp bowing. This needs intervention.
Number 2.
Congenital pseudarthrosis of the tibia, CPT.
Yeah.
Here, the apex is distinctly anterolateral. This is rare, but nearly half of cases are associated with neurofibromatosis type 1.
And this bone has a profound tendency not to heal once it's fractured.
Hence the term pseudarthrosis, or false joint. Treatment is extremely difficult and often requires complex bone grafting and internal fixation.
And the third type?
Apex posteromedial tibial bow. This is generally benign. It improves spontaneously with time, although the limb may end up slightly short. Crucially, it has a tendency to improve without surgery.
Moving to the foot, the management of congenital talipes equinovarus, CTEV, or clubfoot, is one of the greatest success stories in modern pediatric orthopedics.
It really is, and that's due to the standardization of a specific non-operative method.
So CTV is a severe, fixed, multiplanar deformity. We need to anchor the components to make sure no part is missed.
Okay, so the hindfoot is fixed in equinus pointing downward, like a horse's hoof in varus, with the heel turned inward.
The midfoot is fixed in adductum.
Turned inward, yes, and the forefoot is fixed in cavus, giving it an abnormally high arch appearance.
The treatment of choice globally is the Ponseti method of serial manipulation and casting.
And it begins within the first few weeks of birth.
The Ponseti method relies on a very precise sequence of manipulations and long leg plaster casts that are changed weekly.
We can use the mnemonic AVE to remember the correction order.
TED.
C is for correction of the apparent forefoot cavus. This manipulation is done first by lifting the first metatarsal.
A is for
Gradual forefoot abduction. The foot is slowly abducted against the head of the talus, moving it laterally. Correction of the hindfoot varus. The heel inversion is corrected.
And finally E.
Correction of the hindfoot equinus, the downward pointing. This is always the last component to be corrected.
And what's the final, almost universal step?
The correction of equinus almost always requires a percutaneous Achilles tenotomy.
So the Achilles tendon is cut under local anesthesia in the clinic.
To release the heel from that fixed equinus position, allowing the final bit of dorsiflexion. It's an integral, non-negotiable step in the Ponseti protocol for most cases.
The success of the initial correction hinges entirely on the maintenance phase.
Absolutely. If parents fail here, the relapse rate is immense.
Maintenance is the greatest challenge.
It is. The foot abduction orthosis, or FAO, is applied immediately after the final cast is removed.
And it must be worn full-time for 3 months.
And then worn during all nights and naps for up to 4 years of age.
4 years.
4 years. Poor compliance with the FAO is the single biggest cause of relapse. The foot will relapse, almost guaranteed, if the orthosis is not used diligently.
And if the Ponseti method fails, which is more common in non-idiopathic complex cases, what's the difficult trade-off with surgical release?
Extensive surgical release, which involves cutting multiple tendons and ligaments, it achieves the correction.
But
the foot will always be significantly stiffer and weaker than a foot that was corrected by the Ponseti method. The goal shifts to creating a functional foot, accepting that anatomical perfection is no longer possible.
okay, briefly, let's contrast CTEV with a congenital vertical talus, CVT.
CVT is the stiff rocker bottom foot. It looks like a severe flat foot, but the key anatomical fault is a fixed dorsal dislocation of the navicular on the talus.
So the talus is vertically oriented.
Exactly. Treatment involves a complex, often reverse Ponseti technique and limited surgery to reduce the navicular back onto the talar head.
And finally, a rapid review of the osteochondrosis, these localized, self-limiting AVN-like changes.
3 common ones to remember. Freiberg's disease affects the second metatarsal head, causing forefoot pain, typically in adolescent girls.
Okay.
Kohler's disease affects the navicular bone, causing dorsal midfoot pain, usually in younger children ages 3 to 7.
And finally, Sever's disease.
Sever's disease is a calcaneal apophysitis pain at the heel growth plate insertion. And crucially, the radiographic changes you often see in Sever's disease are often just normal calcaneal development.
So they shouldn't be confused with true pathology.
Right. The diagnosis is entirely clinical. #T abnormalities of the upper limb.
We shift our focus now to the upper limb, where the philosophy really changes quite dramatically.
It does. We prioritize comfort and function far more than cosmetic appearance.
Children compensate brilliantly for upper limb deficiencies.
They do. The main concern is function and establishing hand dominance.
One severe anomaly to anger is radial club hand, or radial longitudinal deficiency.
This is a failure of longitudinal formation, where the radial side of the forearm and hand fails to develop.
And this specific anomaly has a high association with other systemic failures.
It does. A radial club hand must trigger screening for the Vactorell syndrome.
Vertebrae, anus, cardio, trachea, esophagus, renal, limb.
Exactly. And the goal of treatment for the club hand itself is to centralize and stabilize the hand on the single bone forearm, which is usually the ulna,
So you're balancing early conservative measures, like splinting and physiotherapy,
with staged surgical interventions, including soft tissue releases and centralization procedures, all to maximize grasp and opposition function.
Wow. We've covered an immense amount of ground. We've traversed the entire spectrum of pediatric orthopedics.
From the molecular guidance systems of embryology all the way to the complex surgical correction of late-stage hip deformity.
And the complexity, as we said right at the beginning, is introduced entirely by growth.
And I think the final key takeaway for you, the learner, is the art of differential diagnosis.
You always have to determine whether you are dealing with a physiological variation that simply needs observation,
Like the varus to valgus progression or flexible flat feet.
or a true, often progressive, pathology.
Like Blount's, rigid flat feet, or DDH. Timely intervention, particularly in the hip and foot, is absolutely paramount.
We established that the paradox of the immature skeleton is that the gift of remodeling is only available if we apply the laws, Hutter-Voltman and Wolff, correctly and promptly.
If we delay, the physis becomes a curse that drives progressive deformity.
Indeed. We noted earlier that DDH, even when it's successfully treated early, significantly increases the risk of osteoarthritis and the eventual need for a hip arthroplasty later in life.
It does. And this leads us to a crucial, final, provocative thought.
We are considering a child who presents with a complex, late-stage bilateral hip dislocation that is well beyond the recommended surgical age limit, let's say 12 years old. If the medical team decides that surgical realignment is too high risk, that it carries an unacceptable risk of AVN, or is simply futile in achieving a functional, durable joint. What critical, long-term, non-operative factors must be prioritized to optimize that patient's future mobility and pain management?
The focus completely shifts away from anatomical correction. The long-term goal has to be acceptance of the current status.
So the team must focus
On maintaining mobility, providing adaptive equipment SOs, bracing, crutches, or mobility aids, robust pain management, and focusing on functional capacity.
walking ability, symmetry, and self-care.
All while balancing cosmetic concerns against the available resources and expertise. Sometimes the best solution is optimizing life with a deformed hip, not risking everything for a perfect one.
A found shift from cure to adaptation. Use this deep dive as your strong conceptual framework, and now immediately return to Chapter 44 of Baily and Love to reinforce these detailed concepts.
Go deep, and we'll see you on the next dive.